Welcome to Stanford Medcast, the podcast from Stanford CME that brings you the latest insights from the world's leading physicians and scientists. If you're joining us for the first time, be sure to subscribe on Apple Podcast, Amazon Music, Spotify, or YouTube to stay updated with our newest episodes. I am your host, Dr. Ruth Adebuya. Today I'm joined by Dr. Kevin Alexander. Dr. Alexander is an assistant professor of cardiovascular medicine at Stanford University School of Medicine, where he treats complex heart failure cases and conducts pioneering research. He specializes in advanced heart failure and cardiac transplantation and is a leading expert in transthyretin cardiac amyloidosis, a frequently overlooked yet life-threatening cause of heart failure, particularly prevalent among African Americans and the elderly. His work is supported by prestigious grants from the National Institutes of Health and the American Heart Association, among others, as he seeks to uncover the molecular mechanisms behind amyloid deposition and improve patient outcomes. Thanks for chatting with me today.
Thanks for having me, Dr. Adebuya.
You have had an impressive career focusing on heart failure and cardiac amyloidosis, particularly within underserved communities. Can you share a bit about what first drew you to this field of cardiology and what keeps you passionate about your work?
Thank you for the question. Early on in medical school, I quickly became interested in cardiovascular physiology and cardiovascular biology in those first couple years of coursework. Rotations that stood out the most to me were my cardiology and cardiac surgery rotations due to the people that I was surrounded with. My attendings were phenomenal physicians. Dr. Jessup, who went on to be the American Heart Association president, and then Dr. Joseph Wu, who was a CT surgeon at Penn at the time, and now is chair of cardiac surgery here at Stanford. I was inspired by seeing their care of patients with advanced heart failure that needed to go on to receive things like heart transplants and left ventricular assist devices. That planted the seed for me in medical school. When I was a resident at Johns Hopkins, really was struck by the breadth of conditions that are treated for cardiovascular patients, in particular heart failure. At Hopkins, we treat a large proportion of patients from the East Baltimore community. I saw a number of African Americans there, and some of them had types of heart failure that seemed refractory to standard medical care. Ultimately, many of them were found to have transthyretin cardiac amyloidosis. That to me is something of why have we missed these patients for so long? And even when we did diagnose them, there were no treatments available at the time. As a physician scientist, that seemed like an area of unmet need to pursue, to not only try to develop novel treatments, but also to improve the recognition and diagnosis of this condition. Those were close to mind when I went to cardiology fellowship in Boston.
Thank you for sharing your story. It's wonderful to hear that you have had such great mentors along the way who have brought you along this journey and have inspired you to continue in this field. Given your extensive experience treating heart disease in diverse populations, and more specifically on amyloidosis in the African community, can you describe the current state of cardiovascular health as it relates to this disease, especially in terms of challenges and progress?
This field has evolved rapidly in the last 10 years. I'm speaking specifically about transthyretin cardiac amyloidosis. Even since I was in training, we went from a disease where there are no treatments available. And the main way we could diagnose patients was with heart biopsy, which is not widely available as a procedure across institutions, to now where in 2018, we had a pivotal phase 3 clinical trial for a therapy called tafamidis, which improves survival. That result, as well as the advent of non-invasive testing for this condition, have really galvanized the awareness of this disease. And so the diagnosis rates have gone up quite a bit. We are diagnosing more patients earlier. Despite all that, though, there's still many patients that unfortunately present to us with advanced disease after seeing doctors for many years. And the treatments that we do have available are less effective or minimally effective in these more advanced stage patients. While we've made progress, there's still a lot of unmet need. And this disproportionate burden of disease tends to cluster in certain groups, one of them being Black individuals. Some of that's because of structural barriers in healthcare in terms of access, which we see in other cardiovascular diseases. And then some specific things among African Americans as well, that there's a genetic variant that's carried by 3 to 4% of Black individuals that increases the risk of developing this. There's some genetic reasons, and there's also some structural reasons why there's a disproportionate burden of this disease among Black individuals.
Striking to see how much progress has been made in a relatively short time, especially with the development of non-invasive diagnostic tools and targeted therapies. The point that you made about the remaining gaps, particularly among Black individuals, it does underscore the need for equitable healthcare access and targeted awareness in vulnerable communities. We know that African Americans experience disproportionately high rates of heart disease. I'd love to get your thoughts about what are some of the key factors that are driving this disparities and how healthcare providers can better address them.
I think it's an important question, and I'll try to cover some of the aspects of that. Certainly, that could be a half-hour conversation in and of itself. There are structural barriers in the healthcare system that affect some populations more than others when it comes to diagnosis and care. And some of those things I think would be recognition of disease, particularly for diseases that are less common, like amyloidosis, or might have varying presentation. So people present with a wide range of symptoms. That can lead to a delay just from needing to happen to come across the right physician, get the right test, to get the diagnosis. So there's a little bit less standardization. Even when there is recognition, knowing how to navigate the healthcare system to get to the right providers to care for these things that are more specialized. Then even after that, access to the therapies, which in the case of amyloidosis and other less common diseases, those therapies can be quite expensive. There's been a lot of work at Stanford with my colleagues and other places to try to address some of these barriers, where I think it's important to try to standardize these areas where there might be heterogeneity in terms of how patients present. In an age where we have electronic health records, a lot of ways to automate screening of clinical data, this is something that can be applied not only to common diseases like hyperlipidemia and heart disease, but also to less common diseases like amyloid, to try to assist the healthcare community, the physicians and nurses, to identify these patients and more rapidly navigate to getting a diagnosis.
I think that's an excellent point. In populations that are disproportionately affected by certain diseases like transthyretin cardiac amyloidosis, one major challenge can be the often strained or limited relationship that those populations have with the healthcare system, which can impact whether individuals seek out timely diagnosis and care. You had mentioned that during your training at Johns Hopkins, you worked with populations in East Baltimore affected by this disease. Could you share some of the specific strategies that you used or are continuing to use to engage the communities and promote awareness? And I'm especially curious about how you facilitate knowledge sharing to help individuals understand the importance of regular assessments and proactive care.
I think you raise a good point that upstream of the recognition and diagnosis piece, do some of these patients even reach the healthcare system? Among the Black community, that's been a challenge. As healthcare providers, we take a more reactive approach of when people come to us, then we start to do these assessments. But what about the folks that never come to us? How do we meet people where they are in their communities to try to bring them into the health system? And also to have that layer of trust and partnership, which I think are really important. We've done a number of studies in recent years looking at some of these social determinants and their relationship to presentation with amyloidosis. We found more recently are things like transportation and household demographics can really affect patients' abilities to come to our healthcare system to receive care, particularly in the advent of things like telemedicine and partnerships with community providers. These are things that can allow us to not wait for people to be referred to us, but meet them and at least start to do those initial screenings and tests in their local environments. That's really important for amyloidosis, but other cardiovascular conditions. The other thing that's key is whenever approaching patients who may have a mistrust of the health system, I think that the message is really important in terms of what the importance of screening and looking for these diseases are. Oftentimes, the message can come across as alarmist or scary in terms of you have this deadly disease, let us screen you, and there's not much we can do about it. In the case of amyloidosis, now that we have these effective treatments that are really good for early stage disease, that message has to be one of hope and one of prevention rather than reacting to things and having a more grim outlook.
So let's dive into the disease and talk about ATTR-CM, which is an undiagnosed cause of heart failure, particularly in older African American patients. Can you explain what this disease is and why it is often overlooked in this population?
Absolutely. Amyloidosis is a group of diseases where a protein somewhere in the body is breaking down abnormally and aggregating. These aggregates of protein are amyloid fibrils. When they build up in various parts of the body, they tend to be progressive diseases that leads to damage and dysfunction and sometimes failure of those organs. I'm a cardiologist, so I'm a little biased, but I'd say amyloid diseases that affect the heart can be some of the most devastating because that amyloid infiltration can lead to arrhythmias and heart failure, and if left untreated, in most cases, death. The most common type of cardiac amyloidosis is due to a protein called transthyretin, which you alluded to. And it's something that we all have that's produced in the liver. In some individuals, that transthyretin protein can start to break down and in large part build up in the heart, but there's other parts of the body. There are certain risk factors that we know quite well. This is aging related disease. So a lot of patients who develop this were older, 60s, 70s, 80s. But then also there are certain racial ethnic groups that are higher risk. In the US, Black individuals have a genetic risk because of this variant in the transthyretin protein called the V122I variant. This is carried in 3 to 4% of African Americans. And so that means there's well over 1 million carriers in the US. Having a mutation doesn't necessarily mean you'll go on to develop amyloid. It does significantly increase your risk. And so that's been shown in a number of large observational studies in recent years. With this risk, there's a lot of patients out there, probably more than what we thought in medical training, where this was considered to be a rare disease. There are many people out there carrying this risk. And then as the population ages, the number of people at risk is also going to increase. Some of the challenges with diagnosing this condition, particularly early, is that the manifestations can be quite diverse and quite subtle and also be similar to other conditions. So with cardiac amyloidosis, the stiffening in the heart, the diastolic dysfunction can lead to shortness of breath, maybe some leg swelling, things like atrial fibrillation. And so there's a lot of things, if you think about a middle-aged or elderly population that could have a similar presentation, hypertensive heart disease, cardiometabolic disease with coronary disease, et cetera. Sometimes patients can have similar symptoms. And then there's also patients, particularly the hereditary ATTR patients, that might have extra cardiac manifestations such as neuropathies and gastrointestinal symptoms. So they may not even present to cardiologists initially, but present to some of these other specialists.
Can we do a bit of a deeper dive, and can you talk more about the different presentations of the disease?
The way I would classify patients with ATTR amyloidosis, so there's individuals who have a normal copy of the protein, and that breaks down and causes disease. And we call that wild type ATTR. That's predominantly seen in individuals that are older, and we think it's mostly age related. And the amyloid deposition that happens in those patients is predominantly cardiac. We don't think that it really causes a neuropathy. The other subset of people with ATTR are those that have a point mutation in the transthyretin protein that leads to a hereditary form of this disease where it has an inheritance pattern. Of those mutations, one of them is the V122I variant. The interesting thing about the mutations are that the presentations can vary quite widely. The V122I variant carried among African Americans is predominantly cardiac manifestations, similar to what we see for wild type. But there are mutations that have almost exclusively neuropathy manifestations or mutations that have a combination of cardiac and neuropathy manifestations. In the US, the variants that cause predominant neuropathy are a relatively smaller proportion of patients compared to some parts of Europe, Asia, where some of those neuropathy variants are actually more prevalent than the cardiac manifestations. I think it's a very interesting disease in that way, and also one of the challenges in terms of how patients present and who they present to. Each patient's unique in terms of how they present. And these subtle symptoms can be challenging to find that needle in a haystack, that one out of however many patients that has this underlying condition, as in contrast to others that have more common diseases causing their symptoms.
What I'm hearing from you is that the complexity of amyloidosis, with its wide range of subtle and overlapping symptoms, particularly in older populations and high-risk groups, makes early diagnosis quite challenging, especially because of how these symptoms can mimic more common conditions. So I'm curious about the diagnostic considerations in primary care or community cardiology settings. Given these subtleties, what would you say are the key factors or flags a family physician or a community cardiologist should consider when deciding whether to screen or refer a patient for further evaluation of cardiac amyloidosis?
I'll answer that in two parts. I think for individuals who are presenting with clinical heart failure, We know that about 1 in 6 of patients with heart failure with preserved ejection fraction, middle or elderly age patients, have underlying TTR amyloidosis. That's a large number of patients if you think about it. If half of heart failure is HFpEF and 1 in 6 of that have TTR amyloid, we're talking tens of thousands, at least probably hundreds of thousands of patients. And so primary care physicians, cardiologists, community cardiologists are going to encounter these in patients routinely. Those patients, it's reasonable to consider amyloidosis, particularly if there's other comorbidities like carpal tunnel syndrome. If there's cardiac imaging, there's signs of left ventricular hypertrophy. So I'd suggest having a low threshold to screen those patients now that we have non-invasive testing. That's a start because we're missing a lot of patients who have clinical advanced disease. Even with those kind of simple steps, that would move the needle quite a bit in terms of identifying patients. Ultimately, hopefully we'll start to identify the vast majority of patients in that pre-heart failure phase where, yes, they have some cardiac amyloid deposition that we could detect on imaging, but they don't necessarily have yet symptomatic heart failure requiring diuretics and leading to functional impairments. And I think that's a little bit more challenging, but I think that's where targeted screening of groups that we know are at risk, so older individuals, African Americans who have a higher risk of carrying the V122I variant, we have to think about ways to screen them. Practitioners and tertiary care centers, we have to think, how can we take some of that burden of screening off the hands of primary care physicians and community physicians? That's where some of these automated tools and EHR-based tools could be effective in identifying those at-risk patients in the community, and then having a way to have those patients evaluated or screened at these amyloidosis centers of excellence. So I think it's those two parts. The people that have heart failure now, raising the awareness community and giving them the tools to screen for patients. And then those pre-symptomatic heart failure patients coming in with a more systematic way of automating screening and getting them to the appropriate providers.
I'm glad you mentioned the essential role that the centers of excellence can play in supporting community cardiology and primary care practices. Given the high prevalence of the genetic mutation, this community-based providers are often the first line of contact, yet they might lack the resources to manage the volume effectively. It's really encouraging to see experts like you working to create a supportive network that can aid these providers in early identification and referral. Shifting to treatment, you've mentioned that we now have some therapeutic options. Could you share more about what treatments are currently available and what's on the horizon?
There's one FDA-approved drug, tafamidis, which I mentioned, that's been out for around 5 years now. In the last year, we've had 2 more pivotal phase 3 trials with positive results. The first is a medication called acoramidis, which also works similar to tafamidis. They're both small molecules that stabilize the transthyretin protein to help prevent it from breaking down. And a little piece of interesting history or trivia, acoramidis was developed at Stanford with a couple of investigators, and then that company went on and was acquired by Eidos and BridgeBio. So some of the roots of that drug development were here at Stanford. That drug is being reviewed by the FDA, and the PDUFA date, or the decision date for that's actually next month. So we potentially will have 2 therapies for this by the turn of the year. The second phase 3 pivotal trial that resulted is for a drug called vutrisiran, a family of medications that lower the production of transthyretin in the liver, thereby having less of that protein circulating around that can go on to develop amyloid. That also showed very positive and encouraging data and is being reviewed by the FDA. So potentially another treatment that's available for the cardiac manifestations of this disease. And there's been a number of that vutrisiran family medications that lower the transthyretin. There's several that are available for people that have the neuropathy form of this disease. And depending on patient presentation, we use that as well. Coming down the pipe, I think that there's a couple of therapeutic approaches that are interesting. One is a gene editing approach where it takes the idea of, we know that lowering transthyretin with these RNAi and antisense oligonucleotide approaches can be effective in clinical outcomes for neuropathy and cardiomyopathy. What about using CRISPR-Cas9 technology and be a permanent solution, a one and done treatment? We're enrolling for the phase 3 trial here at Stanford. That study will be interesting to see how it plays out. And while we had these advances of drugs, small molecules that can stabilize the protein and various approaches for lowering the expression of the protein in the liver, these work more on the prevention side of preventing new amyloid from building up in the heart. That question of what about the amyloid that's already in the heart, many of these patients present with more advanced disease. Are there any interventions to try to remove that amyloid or reverse, remodel the damage that's already occurred in the heart? There's a number of companies that are studying monoclonal antibodies that bind to amyloid with the intention of trying to remove it. There's a number of clinical trials ongoing and multiple ones that we're participating here at Stanford. That's where there is a lot of promise in this field for things that currently improve survival, slow disease, things that are being developed that may complement and further improve outcomes in patients.
That was such a comprehensive overview of the current and emerging treatments for this disease. And it's exciting to hear about the potential approval of acoramidis, especially knowing it was developed at Stanford. Also, the advancements that are happening with gene editing approaches, the prospect of the therapies that not only prevent new amyloid buildup, but also remove existing deposits sounds really promising for patients with advanced disease. Given your involvement with these cutting-edge developments, I'm curious about your specific research at Stanford on this disease. Could you share more about the aspects you're focusing on and how your work is contributing to these advancements in treatment?
I could talk about that for days. We're interested in all things related to amyloid. And so our group does research in amyloidosis from basic science, translational, and clinical. On the basic science side, we're very interested in understanding how amyloid fibrils cause disease in target organs, specifically the heart. And what some of the pathways and things that we're studying are the roles of inflammation in this disease pathogenesis. We know the immune system plays a role at trying to remove amyloid fibrils. And are there things that we can learn from understanding the mechanism of inflammation and amyloidosis to try to promote increased clearance of these amyloid fibrils through natural immune processes? We studied that through a number of model systems, in vitro, cell-based model systems, as well as in vivo with a mouse model. Our goal is to try to identify novel targets that could be complementary to the current therapeutic approaches that we have. On the clinical side, there are two arms. One is we're heavily involved in clinical trials, so enrolling patients in many of the studies that I alluded to. And we're fortunate at Stanford to be a high volume enroller in many of those studies and a leading enroller internationally with our large patient volume. That's something that's really rewarding and exciting to have that option for our patients to have access to current therapies, but then also these novel therapies. I've done some work on clinical trials operation, collaborating with Ken Mahaffey in the Stanford Center for Clinical Research. We co-chaired the clinical events committee for that acoramidis study that I mentioned. That was a great experience and certainly something that we hope to have more opportunities in the future for leading some of the ongoing and upcoming clinical trials in the amyloidosis space. The other area of clinical research that we're interested in is more on the observational study and implementation science aspect. That's where understanding how social determinants of health and other variables affect presentations, how late or early someone presents with ATTR, how can we do a better job of screening for patients in at-risk populations, identifying the problem, but then importantly, want to develop interventions to improve diagnosis in these vulnerable communities. We've submitted a number of papers recently identifying some of these risk factors for a late presentation with disease, and then we'll start to transition into some targeted interventions for identifying these patients in our Stanford and catchment area, but then also try to apply it nationally with collaborating centers.
It's inspiring to hear about the depth and breadth of your team's work in amyloidosis, spanning from basic science to translational and clinical research. And it's clear that it's a holistic approach that is driving meaningful progress towards new treatments. The focus that you have on social determinants and implementation science is especially impactful, which is crucial to advancing equitable care. How does your team manage the challenges of reaching such a geographically and socioeconomically diverse patient population? And what, if any, is the role that the center plays in expanding access to care and research for this patient population?
It is a challenge to pursue all the things outlined just in terms of the scope. I'm very fortunate to practice in an environment where we have a large multidisciplinary center for amyloidosis. Ron Watalis, Mikhail Leakey, Rong Li Liao co-directed the Amyloid Center, and each have strengths in different areas of clinical care and research. That's led to a robust center where we do have a good catchment area and referral system for patients in clinical care, but also for enrolling in studies. We routinely see patients throughout Northern California, in Nevada, going south towards Southern California, and I see a fair number of patients from Hawaii. with that in catchment area, we do see a diverse range of patients in that ecosystem. But even closer to Palo Alto, right, there's lots of patients East Palo Alto, Oakland, East Bay, and then going down towards Monterey that have areas of higher social vulnerability and less access to healthcare. And certainly there are lots of areas of affluence and access to care at tertiary centers, but there's even places closer to home, but then also farther out that have limited access to some of the care for something like amyloid.
What is giving you hope about the future of cardiovascular health, specifically to the work that you're doing in amyloidosis and the community and the population that you serve?
We're entering a period of cardiology where we truly are pursuing personalized medicine. So the clinical trials I mentioned for amyloid, I think that they're novel mechanistic approaches to a specific disease and have been shown to be highly effective time and time again. That's being seen in other areas of cardiology. We'll continue to see that drug development innovation leading to more effective and tailored therapies for patients while also minimizing side effects. The second thing is around the detection piece, where I think that with machine learning and AI, more integrated electronic health records, we'll have the ability to identify these patients who oftentimes have been seen in the healthcare system regularly before we make the diagnosis of whatever condition they have. We'll be able to put those pieces together in a comprehensive fashion and get people to where they need to go sooner. That also makes me optimistic because a lot of these treatments that are being developed work very well or better in earlier stage disease. These two arms, I think, will really lead to improved outcomes.
It's incredibly inspiring to hear your optimism for the future of cardiology and the direction personalized medicine is taking. The advancements in targeted therapies for specific conditions like amyloidosis reflect a shift that truly represents a new era of precision in healthcare. It's been great hearing about the integration of machine learning, AI, and EHR data as another exciting frontier and offering promises of earlier and more accurate diagnoses, and how with the work that you're doing, clinicians will be able to catch conditions like amyloidosis sooner, where treatment is most effective. This conversation has really highlighted how the combination of innovation and early detection can be poised and is poised to make a remarkable impact on patient outcomes. Dr. Alexander, thank you so much for chatting with me today on this topic.
Yeah, thanks for having me.
This episode was brought to you by Stanford CME. To claim CME for listening to this episode, click on the Claim CME link below or visit medcast.stanford.edu. Check back for new episodes by subscribing to Stanford Medcast wherever you listen to podcasts.